And today we are celebrating 3,000 subscribers. Yay! Hey future nurses, welcome back to Scrub and Spoon. How are you all doing? If you are new here, I am Nurse Funke. Okay, glad to have you here. And today we are celebrating 3,000 subscribers. Yay! And I'd like to make a wish. Okay, I would like to make wishes actually, because it's not just one. Now, my first wish is that all nursing students pass their nursing school exam and pass their NCLEX, and that may God continue to help me bring the right information, right topic, right resources to you guys. Okay, my second wish is that this platform will grow million subscribers. Okay, we will get there. So before then, till we get there, let's enjoy the ride. Okay, all right, yay. All right guys, cheers. Now to the business of the day. Our NCLEX review today is on fluids and electrolyte imbalance. We are talking about 6 important electrolytes that nursing students are always tested on. We are talking about sodium, potassium, calcium, magnesium, phosphate, and the last one, chloride. And the last one, chloride. Okay, so watch till the end. There's a lot to learn. It's a robust review. Watch till the end. Share my videos, my other videos, and this video to other nursing students that you think will benefit from this review. Okay, and as always, don't forget to check out my website for the 11 body systems and over 120 NCLEX most tested disorders. Okay, let's go right into it. Now, first question: a client's serum potassium is 6.2. Which assessment findings should the nurse expect? A, muscle weakness and decreased deep tendon reflexes. B, constipation and polyuria. C, tremors, hyperreflexia and tetany. And D, excessive thirst and dry mucous membrane. Guys, pick your answer. Guys, the right answer is A, muscle weakness and decreased deep tendon reflexes. Let me explain this to you. What's happening here? The situation we have here, we have high potassium, hypercalcemia. Normal potassium is between 3.5 to 5. Now, this patient potassium is 6.2. We are dealing with hypercalcemia. So what the question is simply asking us is signs and symptoms of hypercalcemia. Our right answer is muscle weakness and decreased deep tendon reflexes. Okay, other signs and symptoms you will see with hypercalcemia will be bradycardia, hypotension, dysrhythmias. You would also see muscle cramps and weakness, and you will see dysrhythmias because what is the function of potassium? Potassium help the cardiac muscle to contract and pump blood to the rest of the body. So when you're thinking about potassium, think about P. P for potassium, P for pump. The potassium help the cardiac muscle to pump blood. Okay? And when there is too much potassium, hypercalcemia is very dangerous to the heart. Now let's go through the wrong choices. B says constipation and polyuria. You will see constipation. Constipation is typical of hypercalcemia. Okay? You will see constipation in hypercalcemia and not hypercalemia. And then polyuria. You will see polyuria in diabetes insipidus. You will see polyuria in hyponatremia. You can also see polyuria in osmotic diuresis, when the kidney makes the body to lose fluids through urine. Constipation and polyuria are not typical, are not the signs and symptoms you will see in hypercalcemia. So that is wrong. And C says tremor, hyperreflexia, and tetany. Now, these signs and symptoms listed are typical of hypocalcemia or hypomagnesemia. Why? Let me explain something to you. Because when you're thinking about, now we're talking about calcium, let's deviate a bit because we're talking about the signs and symptoms related to hypocalcemia. That's why we're talking about calcium. When you want to remember the signs and symptoms related to hypercalcemia, no, you will see in hypercalcemia, you will see decrease neuromuscular function. Let me explain it again. In hypercalcemia, you will see the signs and symptoms relating to slow, decrease deep tendon reflexes. You will see constipation, you will see muscle weakness, you will see nausea, you will see kidney stone in hypercalcemia because everything is low. Like I said, hypercalcemia, high calcium, reduces smooth muscle activities. Now, this is the reverse. In hypocalcemia, now, there will be increased neuromuscular function. There will be hyperactivity. of the muscle. There will be hyperactive muscle, hyperactive nerves in hypocalcemia. So you see it's reverse. So in hypocalcemia, you will see hyperreflexia. So these tremors, hyperreflexia, and tetany are typical of hypocalcemia and hypomagnesemia. I took my time to explain both hyper and hypocalcemia so that you guys can understand why we are picking, why I said tremors, hyperreflexia, and tetany are typical of hypocalcemia and hypomagnesemia. Because you will see typical of the same signs and symptoms in hypocalcemia and hypomagnesemia. Okay? So that makes C also wrong. And D, excessive thirst and dry mucous membranes. Now you will see this in hyponatremia, high sodium level in the blood. Now let me explain why you will see excessive thirst and dry mucous membrane in hyponatremia. Because when there is high sodium in the blood, remember the phrase that says where sodium goes, water follows. Sodium will pull out water from the cell into the bloodstream, and that will cause the cell to dry up. That will cause dehydration. And now because the fluids in the body are now low, that will cause the tissue to become dry, and that will lead to dry mucous membrane. Okay, so excessive thirst and dry mucous membranes are typical of hyponatremia and not hyperkalemia. Okay, let's move on. Next question says, a nurse is preparing to give IV potassium chloride to a patient with serum potassium 3.0. Now, which action is most important before giving potassium? A, administer IV push potassium to rapidly correct level. B, check the patient's urine output and renal function. C, give a bolus of IV normal saline first. And D, hold all oral potassium supplements for 24 hours. Pick your answer, guys. Now, before I tell you the answer, let's see what's going on here. That will help you. We are dealing with hypocalcemia, low potassium. Normal potassium range from 3.5 to 5. We have the range given to us is 3.0. So we have to do something. We have to replace potassium, because that's one of the treatments of hypocalcemia. You replace potassium. And how do you replace potassium? Potassium supplement can be given, and potassium-rich food can also be encouraged. Now, to our situation, the situation we have here is that the potassium is low, and the nurse want to give IV potassium chloride. So what do you check before giving potassium? That's simply the question. And our right answer is B, check the patient's urine output and renal function. And why are you checking this? Let me explain it to you. You are checking the kidney function and the urine output, because kidney help to excrete excess potassium out of the body. Now, if the kidneys are not functioning properly, if there is kidney impairment, the kidney will not be able to excrete that potassium. And that accumulation of potassium in the body will lead to what? Hypercalcemia. Hypercalcemia is very dangerous to the heart. We know that. Hypercalcemia will slow down and disrupt electrical signal of the heart. And so that's why hypercalcemia is very dangerous to the heart. And that's why you have to check kidney function. And how do you know about kidney function? You check the BUN and the creatine level. That will tell you how well the kidneys are functioning. Now, also for the urine output, urine that is less than 30 mils per hour shows you something is going on with the kidney. That's why our right answer is to check the patient's urine output and renal function. Now let's go through the wrong choices. A says, administer IV push potassium to rapidly correct level. Let me tell you this. Never you push potassium IV. Immediate, instant cardiac arrest is what that will cause if you push potassium via IV. If you give rapid infusion of potassium, that's what I'm trying to say. Instant cardiac arrest for your patient. You don't want to lose your license. So never, this option A is very wrong. Never you push IV potassium. It is infused slowly, and it is always diluted. Potassium is diluted and infused slowly. It's diluted with IV fluids. Never push potassium IV. Okay, so that is wrong. Now C, give a bolus of IV normal saline first. First, IV normal saline should not be the first resolution or treatment, because IV normal saline does not directly treat hypocalcemia, low potassium, and it is not required before giving potassium. You do not have to give normal saline before giving potassium, except there is any other reason it was ordered to give it before giving potassium. Okay, normal saline, which is sodium chloride, can be used to treat sodium imbalance or to correct dehydration. So it's not the first thing you give instead when there is hypocalcemia. D, hold all oral potassium supplements for 24 hours. what is the situation at hand? We are dealing with hypocalcemia. Potassium help the cardiac muscle to contract and send blood to the rest of the body. We need potassium. We need to get that potassium to the normal range. So why are you holding potassium? They need it. So patient needs potassium replacement and not restriction. So why are you holding it? So that is very wrong, okay? So let's move on. A patient with serum sodium of 122 is being assessed. Which signs and symptoms is most consistent with this result? Now, A, polyuria and dry mucous membranes. B, confusion, headache, and possible seizures. C, muscle weakness and flattened T waves on ECG. And D, decreased deep tendon reflexes and constipation. Pick your answer, guys. Guys, the right answer is confusion. B, confusion, headache, and possible seizure. What are we dealing with? We are dealing with hyponatremia, low sodium. The patient have sodium level of what? 122. Normal potassium, normal sodium level is 135 to 145. Okay, so we are dealing with hyponatremia. And what are the signs and symptoms? You will see. Now let me explain this before signs and symptoms. When there is hyponatremia, what happens in hyponatremia? In hyponatremia, that is low sodium in the blood. Water moves or shifts into the cell and cause cerebral edema and cause the brain to swell. And we know that the brain is very sensitive to sodium changes. And that's why you see all those neurological signs and symptoms, confusion, headache. And what other thing did they mention? And possible seizure in severe hyponatremia. Okay? You can also see disorientation, lethargy. Seizure can also lead to coma in severe hyponatremia. That's why our right answer is B. Okay? So in hyponatremia, the signs and symptoms you will really see are very typical of neurological signs and symptoms, confusion, headache, all of that. Now let's go through the wrong choices. A says polyuria and dry mucous membrane. I thought I've explained this earlier, that this is typical of hyponatremia. Hyponatremia, polyuria. And why? Because in hyponatremia, water will shift out of the cell into the bloodstream with the sodium, because hyponatremia is high sodium level in the blood. So water will shift out of the cell into the bloodstream with sodium, and the cell will become dehydrated. And once the body notices there is less water, fluids in the body, the tissue also becomes dry. So you will see dry mucous membrane. And you will see polyuria, because now that there is so much water in the blood, the kidney will think, what can I do to get rid of this? The kidney will try to excrete the urine, excrete the water through urine. Okay, so that's how you will see polyuria and dry mucous membrane in hyponatremia. So this is wrong. We are dealing with hyponatremia. So these signs and symptoms are typical of hyponatremia. C, muscle weakness and flattened T waves on ECG. These are typical of hypocalcemia, not hyponatremia. We're dealing with sodium here and not potassium. So that is wrong. Okay, you need to know that sodium affects brain and fluid balance, while potassium affects muscle and cardiac rhythm. So that makes that wrong. And D says decreased deep tendon reflexes and constipation. This is typical of hypercalcemia. In hypercalcemia, everything is low. Constipation, kidney stones, decreased deep tendon reflexes. Because in hypercalcemia, there is decreased neuromuscular function. Okay, so that is also wrong. Okay, sodium imbalance does not directly cause constipation or reduced reflexes. So that's wrong. Now let's move on. Select all that apply. Which of the following are common clinical manifestation of hypocalcemia? A, positive Chivostek sign. B, polyuria and polydipsia. C, muscle tetany and paresthesia. And D, kidney stones and constipation. All right, guys, since it's select all that apply, we treat it as true or false. So let's go through it together. What do we have here? We are looking for signs and symptoms you will see in hypocalcemia. Now, A says positive Chivostek sign. Absolutely. Hear me and hear me well. Positive Chivostek sign and Trousseau sign and positive Trousseau signs are hallmark of hypocalcemia. And what is Chivostek sign? And what is Chivostek sign? This is when you tap someone's cheek, they have facial twitching. That is when you tap the facial nerves, the cheek starts twitching. That is Chivostek sign. And Trousseau sign is when you place blood pressure cuff in patient's hand. Maybe you are taking blood pressure, and the patient can start going like this. That's Trousseau sign. Both these are typical of hypocalcemia. Okay. Another typical signs of hypocalcemia is tingling around the mouth and fingers or even toes. Okay, so Chivostek sign is very right. Okay, now let's go to B, polyuria and polydipsia. You will see this in diabetes mellitus, polyuria, or if you will see polyuria also in diabetes insipidus. We'll be talking about diabetes insipidus and diabetes mellitus soon. Okay, so polyuria and polydipsia are not typical of hypocalcemia. That is wrong. C, muscle tetany and paresthesias. Absolutely, this is wrong. This is right. Sorry, this is right. You will see paresthesias. This is numbness or tingling that I've mentioned around the mouth, around the fingers, around the toes. Typical of hypocalcemia. I mentioned it when I was explaining the first option. So that is right. Okay. And tetany is involuntary muscle contraction or spasm. You will see this in hypocalcemia. So that is also right. True. Now D, kidney stones and constipation. Incorrect. False. Typical of hypercalcemia. You know, I told you with hypercalcemia, everything is low. Constipation, kidney stones, muscle weakness. So this is wrong for hypocalcemia. Decreased reflexes, you see it in hypercalcemia. So this is wrong. Okay, so kidney stones and constipation are not typical of hypocalcemia. They belong to hypercalcemia signs and symptoms. Now let's move on. So our right answers, our right choices that are true is A and C. Now, next question. Patients with chronic kidney disease often develops hyperphosphatemia. Now, which effect on calcium would you expect and why? Now, A says increased serum calcium because phosphate and calcium ride together. B, decreased serum calcium due to inverse relationship mediated by parathyroid hormone. C, no changes in calcium because kidneys only regulate phosphate. And D, increased ionized calcium because phosphate binds albumin. Guys, the right answer is decreased serum calcium due to inverse relationship mediated by parathyroid hormone. Let's see what's happening here. If you've seen the other video I made a detailed video about this 6 electrolytes, the treatment option for when they're hypo or when they're hyper, the signs and symptoms. Go review it. It's very beneficial to you. In that video, I mentioned that calcium and phosphate, they have inverse relationship. And what do I mean? When calcium goes up, and they are both controlled by the parathyroid hormone and the kidney excrete them. When calcium goes up, phosphate goes down, and vice versa. So, which means in chronic kidney disease, the kidney cannot excrete phosphate efficiently, and this will lead to phosphates rising in the blood. This will lead to hyperphosphatemia. Okay, and now, like I've said, that phosphate and calcium have inverse relationship. Now that there is increased phosphate in the blood, there will be decreased calcium, and that's why our right answer is decreased serum calcium due to inverse relationship mediated by parathyroid hormone, PTH. Do you get it? Okay, so that's our right answer. Let's go through the wrong choices. A says increased serum calcium because phosphate and calcium rise together. They have inverse relationship, like I've explained. They do not rise together. So there will not be increased serum calcium. There will be decreased serum calcium because phosphate is high. Do you get it? So that is wrong. High phosphate will usually lower calcium, okay, due to the binding and limited vitamin D activation. You know, vitamin D helps calcium absorption too. So that makes option A wrong. Let's go to C. B is our right answer. C, no change in calcium because kidneys only regulate phosphate. Kidney regulates both phosphate and calcium, so there will be change in calcium. So this is wrong. And D, increased ionized calcium because phosphate bind albumin. No, phosphate binds free calcium, and that will lead to reduced ionized calcium, not increase it. So this answer D, that say increase ionized calcium, no, it will decrease it because phosphate does not bind to albumin, it binds to free calcium, and that will cause decreased calcium. Okay, so that is wrong. Next question. A patient has serum magnesium of 0.9. Which clinical finding should the nurse anticipate? A, diminished deep tendon reflex and hypotension. B, hyperreflexia, tremors and possible seizure. C, flaccid paralysis and respiratory depression. And D, bradycardia and widened QRS complex. Guys, the right answer is B, hyperreflexia, tremors and possible seizures. Now, why? Because hypomagnesemia, increased neuromuscular activities, cause hyperactive muscle, hyperactive nerves, overactive reflexes, Okay, so that is why you will see all this high hyperreflexia, tremors, possible seizures. Okay, let's move to the wrong choices now. A says diminished deep tendon reflexes and hypotension. This would be typical of hypomagnesemia because they have opposites. In hypomagnesemia, there is decreased neuromuscular function, there is decreased reflex, and that's why you see diminished deep tendon reflex and hypotension. In hypermagnesemia, everything is low, while in hypomagnesemia, everything is high. It's the opposite way, so I need you to get it. Okay, so diminished deep tendon reflexes will be seen in hypermagnesemia. Now let's move. C, flaccid paralysis and respiratory depression. Hypermagnesemia. You will see this in hypermagnesemia because everything is low. You see low respiratory depression, flaccid paralysis, hypermagnesemia. That's so for you will not see that in hypomagnesemia. Oh guys, I didn't tell you the normal range for magnesium is 1.5 to 2.5, so we are dealing with hypomagnesemia. Okay, so flaccid paralysis and respiratory depression is for hypermagnesemia. Like I've told you that low magnesium will cause overactive muscle, hyperactive nerves. Okay, now D, bradycardia and widening QRS complex. This is not seen in hypomagnesemia. This will be seen in hypermagnesemia or hypercalcemia. These are cardiac conduction effects that you see in severe hypercalcemia or hypermagnesemia. Okay, next question. A patient receiving an infusion of large volumes of normal saline develops hyperchloremia, high chloride. Now, which acid-base disturbance is the nurse most likely to assess? A, metabolic alkalosis. B, respiratory alkalosis. C, metabolic acidosis, bracket non-anion gap. And D, respiratory acidosis. Pick your answer, guys. Guys, the right answer is C, metabolic acidosis, non-anion gap. Let me explain why. You see what's happening here? We are dealing with high chloride, hyperchloremia. And what are they taking? They are taking normal saline. What is normal saline? Sodium chloride. Now, when a patient takes large volume of normal saline, which is sodium chloride, chloride rises in the blood faster than every other electrolyte. Now, what happens next is that bicarb, which is the base in the body, will be reduced or will go down, and now this will lead to the blood becoming more acidic, and we'll have metabolic acidosis, non-anion gap. So in simple terms, when there is too much chloride in the blood will become acidic, and the once the blood is acidic, that means there is less bicarb, and that will lead to metabolic acidosis in simple terms. Okay, now let's go through the wrong choices. A says metabolic alkalosis. Now, metabolic alkalosis will occur when there is chloride loss, but what we have here is hyperchloremia, high chloride, so that's why we have metabolic acidosis. And chloride loss can include diuretics, taking diuretics, or even vomiting. So metabolic alkalosis will happen when there is chloride loss, and not when, because the situation we have is high chloride. So A is wrong. B, respiratory alkalosis. Respiratory alkalosis is caused by hyperventilation. I've explained that in my acid-base imbalance video. Hyperventilation. Okay, so chloride excess chlorides from IV fluids does not directly affect the CO2, because in respiratory alkalosis, we've blown out of the patient has blown out all the CO2, and that's why we have respiratory alkalosis. But chloride doesn't affect CO2, so that's wrong. And last thing, D, respiratory acidosis. Respiratory acidosis will happen with hypoventilation, too much retention of CO2, decreased respiratory rates, retained CO2, respiratory acidosis. Okay, let's move on. A patient is admitted with serum calcium 12.2. Which signs and symptoms would the nurse most likely observe? A, positive trisol sign and carpopedal spasm. B, hyperreflexia and paresthesia. C, muscle weakness, decreased deep tendon reflex and constipation. And D, hypotension and prolonged QT interval. Please pick your answer. So guys, what are we dealing with here? We are dealing with hypercalcemia. Normal calcium range is 9 to 11. And guys, some of this range might not be the same thing in your textbook, depending on the resources your school is using. But the ranges will not be far-fetched, okay, from each other. So we are dealing with hypercalcemia. Normal calcium level is 9 to 11. So use the mnemonic, call 911 to remember. When you remember, call C, that's for calcium. And 911 means calcium range between 9 to 11, to remember the ranges for calcium. Okay, so we are dealing with a calcium level of 12.2, hypercalcemia. And then, so what they're asking us are signs and symptoms we see in hypercalcemia. And if you've been following me and listening for this amount of time, I've been saying it, that with hypercalcemia, everything will be low. And that's why our right answer is muscle weakness. C, muscle weakness, decreased deep tendon reflexes in constipation. In hypercalcemia, you also see kidney stone, nausea, confusion in severe cases, okay? And hypercalcemia also slows down smooth muscle contraction. That's why you see that constipation. Now, that's our right answer is established. Now, let's go through the wrong choices. A says positive trusal signs and carpopedal spasm. Carpopedal spasm. Where would you say that? Even if you don't know about carpopedal spasm, trusal sign. I know you might be looking for Chivostek sign, but we have carpopedal spasm here. But with positive trusal sign, you should know that we're talking about hypocalcemia. Okay, so that is wrong. So B, hyperreflexia and paresthesia. Hyper. You see that in hypocalcemia. In hypercalcemia again, sluggish, slow, reduced muscle activity. But hyperreflexia, hyper, you will see that in hypocalcemia. Okay, so B is also wrong. And D, hypotension and prolonged QT interval. Yes, hypercalcemia will cause QT interval, but not prolonged QT interval. It will cause shortened QT interval, not prolonged. So that is why this is wrong, even though it causes QT interval but not prolonged. So that is wrong. So our right answer is C for hypercalcemia. Everything is sluggish. You see muscle weakness, decreased deep tendon reflexes, constipation, kidney stones. Next question. A patient develops Torsades de Pointes, now, which is polymorphic ventricular tachycardia after a medication overdose. Which electrolyte therapy is commonly given emergently? A, IV calcium gluconate. B, IV magnesium sulfate. C, rapid IV potassium chloride push. And D, IV sodium bicarbonate. And guys, the right answer is B, IV magnesium sulfate. Now let's go through it. You see what this patient is experiencing. Torsades de Pointes is a life-threatening ventricular arrhythmia, often associated with hypomagnesemia, low magnesium. So IV magnesium is the standard treatment option for Torsades de Pointes, because IV magnesium sulfate will help to stabilize cardiac myocytes. It also helps to suppress early after depolarization that actually triggers that Torsades de Pointes. Okay, that ventricular, what is it called? Polymorphic ventricular tachycardia. Okay, so that's why we'll give IV magnesium sulfate, and you will give this even if magnesium level is in the normal range. Once the patient have this Torsades de Pointes, IV magnesium sulfate is given. Now let's go through the one choices. IV calcium gluconate. This is used for calcium channel blocker overdose, and not Torsades, because even though calcium may help to stabilize the cardiac membrane, but it does not treat the Torsades, and that is why calcium gluconate is not the right answer. C says rapid IV potassium chloride push. I have said it a million times. Never push IV potassium. Cardiac arrest, instant cardiac arrest. You don't want to lose your license. That is really wrong. And potassium is used to correct hypocalcemia. And what we're talking about here is magnesium. Hypomagnesemia is what causes the Torsades de Pointes. Okay, so that is wrong. D, IV sodium bicarbonate. Now this is used for when patients overdose on antidepressants, the TCAs, tricyclic antidepressants, and not for Torsades. This does not terminate Torsades de Pointes. Okay, next question. Which snack choice is highest in phosphate and would be appropriate to treat a patient who needs increased phosphate intake? I mentioned all of this in that other video. Okay, now A, plain baked potato. B, Greek yogurt and pumpkin seeds. C, apple slice and almond butter. And D, carrot and hummus. Guys, the right answer is B, Greek yogurt and pumpkin seeds. Now dairy products like yogurt and seeds like seeds and nuts like pumpkin seeds are high in phosphate. So combining the Greek yogurt and pumpkin seeds offers rich phosphate or high phosphate content, and this is appropriate in increasing dietary phosphate intake. Okay, now let's go through the wrong choices. A says plain baked potatoes. Baked potatoes may contain phosphate, but they are less compared to when you take it from yogurt and seeds, like pumpkin seeds or nuts, right? So that is wrong. C, apple slices with almond butter. They do not have enough phosphate compared to taking yogurt and pumpkin seeds. D, carrot and hummus. They are relatively low compared to the amount of phosphate you will enjoy or see in Greek yogurt and pumpkin seeds. So the one that have highest rich, the one that is rich in phosphates is B. Okay, let's move on. Now, select all that apply. Which foods are good dietary source of potassium? A, banana. B, white bread. C, avocado. And D, hard candy. Guys, the right answer is A and C. Banana, rich in potassium, and avocado. Because bananas are classic high potassium foods. And also avocado is also high in potassium. Wrong choices. White bread, carbohydrates. Low potassium, more of carb, right? And hard candy, sugar. There is no significance. There is no potassium in candies. Sugar, okay? And guys, I didn't realize we've gone through all of our questions. Thank you for watching till the end. Stay safe. Bye.